Okay, so let's talk about phase 1 and phase 2 reactions. So what the liver is doing when it extracts a drug, it sometimes can eliminate the drug, but usually not. What it's doing is it will transform that drug into something that makes it more polar, water soluble, and the kidneys can get rid of it. So phase 1 reactions, the liver attaches to that drug small entities like sulfhydryl groups or hydroxyl groups that make it more polar and usually decrease the activity of the drug or the newly formed metabolite or inactivate it. So it could be inactivated at that point. And then as it is released and circulates through the blood, the kidneys will pick it up and get rid of it because it's so polar. Phase 2 reactions are where there's a conjugation, usually a much larger molecule like glucuronic acid, sulfuric acid. It'll conjugate with that, with the metabolite or the parent drug. And again, in order to make it more polar, more likely to be eliminated by the kidney. Again, sometimes those metabolites are retained some metabolic or some pharmacologic activity, and sometimes they lose all of that. So the big thing to keep in mind is that one of the liver's jobs is to transform the drug, the parent drug, into a substance that is more readily eliminated, usually by the kidney. And we call them phase 1 and phase 2, but they don't always go in that sequence. Sometimes you can have a phase 2 reaction where conjugation will take place first. Or you'll also hear the word glucuronidation used. Glucuronidation is just one of the forms of conjugation. And it's a common one. So there are myriad of enzyme systems in the liver that can metabolize drugs. The most common and predominant are a system called the cytochrome P450 system. Is that one you're familiar with? Have you heard that term before?
Yeah.
Okay, some have. Cytochrome, so just telling you, it sits on those, usually on the cells, and it's just a system, it's a classification of enzymes. This says there are about 50 of them, about 50 isoforms of these different enzymes. 6 of the types metabolize about 90% of drugs, and the 3A4 is responsible for about 50%. The reason I'm telling you about these is that this is where the majority of drug interactions occur. So I'm going to talk, when we get into drugs, I'm going to talk to you about if you give this drug with a 3A4 inducer or inhibitor, you're going to have trouble with that drug. You're going to either make it more toxic or you're going to inactivate it. That's why this is important. So you can see by that pie graph is that the 3A4, the 3As are the most predominant when we come to drugs. The 2D6 and the 2C9s are also common. They're maybe 10 to 20% of all drugs. Okay, so that's one thing to remember. P450 system metabolizes most of the drugs that we use, and that's where the interactions are going to occur. Now talking about types of interactions. So we can consider drugs are a substrate for these enzymes. And that's what they do their work on, and they inactivate them or make them less active. We can rev up those enzymes. We can increase their ability to metabolize. So we call that induction or inducing enzymes. We've increased their capacity. There's more of them, or they can do it faster and more effectively. Okay. If you induce enzymes for a drug that you have given that is metabolized by that enzyme, it's going to get rid of it more quickly. So what do you think pharmacologic effect's going to do? It's going to be less. I can get rid of you faster, so there's less of you around to do the job. So if you give a drug with another drug that induces enzymes, then the effect of that, you effectively decrease the ability of that drug to do its work. Okay, so that's induction. So know that this is an important concept, and we'll go back to it over and over and over again. I will talk to you about 3A4s until your brains fall out when we get to drugs, because they are so common in terms of their effects on metabolism and effectiveness. Yes?
So in what kind of situation would you want to give a drug where you are enhancing the P450 enzymes?
I can't, nothing comes to mind where we would deliberately do that.
So it's usually just unintentional?
You're just going to have, it's when you're using a lot of drugs together, this will come into play. So the opposite can also occur. Yep. Question. So the other is inhibition. So we can inhibit enzymes. And so if we inhibit them and you can't get rid of them as fast, then is the amount of drug around going to be more or less? More. So your effect of the drug is going to be greater. If we give a cholesterol-lowering medicine at the same time that we give a drug to treat toenail fungus, pretty common in diabetes, that toenail fungus drug can so inhibit the ability to get rid of that cholesterol drug is that we get a whole lot more of that drug around. So usually what we have to do is when we are giving drugs where we know that interaction is going to occur, we have to change the dose. So we lower the dose of the cholesterol-lowering agent because we can get the same effect and we can minimize toxicity. Amiodarone, a drug to control heart rate, and warfarin. It so impacts the ability of the amount of warfarin that we can give and its half-life is like 60 days. So the effect is very long. So we know that even when we stop the amiodarone, we have to monitor and change the warfarin dose over a couple of months. Okay. So that's where that comes into account. You have to make adjustments. Very important. These are basic things that we will use over and over and over again. Other factors that can affect metabolism, other diseases can affect. So you're looking up there and you go, liver, okay, I got it. Liver can't function, that's going to have an effect on metabolism. But where does the heart come into it? Well, the liver and blood that goes then to the heart are very well connected. So if the heart cannot pump and you have a heart failing, what happens to the liver? It gets congested, liver gets bigger. And it won't work as well. So when the heart is not working well and it's decompensated or it's in fulminant failure, then our ability to metabolize drugs really goes down. So that's where heart disease fault comes in. Concurrent medications, I've already given you numerous examples, or some examples on that. Nutrition. Grapefruit juice is a huge problem with people who are on multiple medications. That grapefruit can wreak all kinds of changes in enzymes. It's amazing. So often, and there are predominant ones. When we get to those, I'll point them out. But that is probably one of the strongest things we have with nutrition. Charring meat, eating a lot of grilled meat can change some drugs. The change of whatever it does to those proteins also can affect the liver's ability to metabolize drugs. Smoking. Smoking can rev up those enzymes so that you have to get very high doses of some drugs to overcome that. Likewise, if they back down on smoking, those enzymes come back down to normal, then you've got more drug around than you had planned on. Alcohol, the same thing. Alcohol it's such a wicked thing to deal with when you're using drugs, because if you acutely drink, if you have somebody who's coming in on a Monday or a Tuesday, and they have binged all weekend, then you get acute injuries to the liver. And it's like you stun the liver, and it just does not work as well in metabolizing some drugs. Okay? So that's one effect. If you're a chronic drinker, let's say you drink most nights of the week, even if it's a little amount, you rev up those enzymes. So acutely, you can shut them down to an extent, but if you chronically drink, you increase the enzymes activity. So then you get somebody who chronically drinks and has a bender on top of it. Makes it hard to figure. So you have to have that as part of your questioning and figuring out when you're not getting an effect that you expected. Fevers tend to change the effectiveness of enzymes, and it can go either way. Usually it will decrease the effectiveness of those enzymes. Infections, same way. Inflammation, all those tend to reduce enzymatic effect. Stress. High stress sustained, greater than just the stress you're just, momentary or regular stress of life, can also change the, so we're talking about huge sustained stress. When you all get into a few months and you've got that high sustained stress, then we could certainly see changes in your ability to metabolize drug. Age. The extremes of age, we can see really big differences. Children, when babies are born, some of their enzyme systems are not mature, and some of them take a year to mature. Extreme of age, older folks than the old, they have less ability to metabolize drug. Body composition, sometimes the amount of fat that you carry around will change the way a drug distributes and how effective it can be. We'll see that with a lot with the hormones. Cancer. Cancer has all kinds of things that change the body. Inflammation is one of them that will also can change the metabolism. Again, with a drug, it's the sum total of all these things. If it's stable in a person's life, then the dose you get, you're probably going to get the effect you want and minimize the side effects. It's when changes come on top of that or they do something different that then can change the metabolic capacity and the effectiveness of the drug or the toxicity of the drug. Okay, so let me stop there. Questions about that? This is like a broad sweep. It's like a canvas and you just take your brush and go across it. So it's just big things because when I start to talk about them, when we use drugs, I want them to be familiar. And so it will start to make sense as we see more real-life application of these. But it also tells you that you also need to know who to go to, because you're going to see things in practice and you're going to go, what is that? The longer you do it, the more experience you have, the more likely you'll figure those things out. But there is so much knowledge now and such development of professionals that you really need to start to learn is who do you go to? Who do you go to when you're unsure or don't know? So that ability to appreciate what other professionals bring to the care of a patient is also an important part of your education. Okay, let's talk about elimination or excretion. So this is permanently removing the drug from the body. Lots of organs play a role. Liver and kidney are predominant. Kidney, I would say here, is predominant in getting rid of drugs. Multiple organs are involved, so elimination is usually the sum total of all of those tissues doing their job. But predominantly, we'll see some organs play a bigger role, and kidneys would usually be that. Okay, so now we're going to get back to steady state and half-life. So the elimination of a drug can be derived from its elimination half-life. So this is important. What I put in yellow is important to remember and to always keep with you when we're talking about drugs. The half-life of a drug is the time required for the plasma level of the drug to decline by 50%. Half-life half-life affects dosing intervals. The longer the half-life, usually the longer we can give the drug. I put this up for several reasons. One, to just kind of show you a visual. So one half-life, you've got rid of 50%, or 50% of the drug remains. After 2 half-lives, 25% remains. After 3 half-lives, 12.5% remain. After 4, 6.25. And by the time you get to 5, you've got pretty much all the drug gone. This is important in terms of knowing how long it's going to take you usually to get to maximum effect of a drug. It's also going to tell you once I stop giving a drug when it will all be gone. It also plays into steady state. So steady state, each of these would be a half-life. 1, 2, 3, 4, 5. Okay. So it usually takes 5 half-lives of a drug to get to full steady state. Now, you will see it listed differently because people will use these numbers a little bit differently. So you can see after 1, 2, 3, and a third, you're at about 90% to the steady state. So some people will say time to steady state is 3.3 half-lives. It's not wrong either way. 5 is full, it's easy to remember, but 3.3 you will also see used because of the 90%. Likewise, if we stop the drug here, it would take 5 of those to get back down to 0. Questions about that? Now, someone brought up at the break, tell me your name.
Brad.
Brad. So Brad brought up at the, about SSRIs and why do you have to take them for 3 to 4 weeks to see effect when maybe the half-life is 6 hours, something like that. So achieving steady state does not always mean you've got maximum effect because you're also having to account for what is going on in cellularly and what changes that drug is making. Drugs like TZDs, which is a drug to treat diabetes, you have to take for 3 months to see maximum effect. Gemfibrozil, a drug to lower cholesterol, you have to take 3 months to see effect because of what it is doing at the tissue level or cellular level. So steady state, it does tell you when you have gotten to where input and output have now become in equilibrium. These become really important when you get to antibiotics and you're giving them IV because you quickly want to get to steady state with them. And so sometimes we'll load and give a large dose to try to get to steady state even faster, especially if there's, depending on the state of the patient. Okay, so questions about steady state. Important concept, yes.
So it takes 4 to 5 half-lives for the drug to become the steady state, or to get to the steady state?
To get steady state, right.
So it's also 4 to 5 half-lives for it to get to the full.
Back to 0.
Okay.
And now any drug monograph you look at, it will tell you the half-life of a drug. It'll always be something you can find. Okay, let's talk about linear and nonlinear kinetics. Linear kinetics are easy because the steady state concentration changes proportionately to the amount of dose. You increase the dose, the steady state will proportionately increase. So it's a straight line. Most drugs will follow linear kinetics. Increase the dose, the steady state levels are going to be higher. Nonlinear kinetics is where you get the doubling of the dose or any multiple increase of the dose does not give you a linear line. It gives you a greater effect than just the percent or the proportion that you increased it. We can show you an example. Here's Dilan. So this is a drug that we use for to treat seizures, anticonvulsant drug. It follows nonlinear kinetics. And you can see that by the dose concentration curve. So here's our target concentration range or therapeutic window right here between, this is in micromoles per liter, it would be like 10 to 20 milligrams per deciliter is the target range. Fairly narrow. This is one of those narrow therapeutic index drugs because once you get above 20, then neurologic side effects start to show up. They can't walk straight, they get ataxic, they have nystagmus. So right above, and even in the higher ends of the therapeutic range, you can start to see those toxicities show up. So here you see when you increase a dose of 200 would not be an unreasonable, it would be a low dose, and you go up to 400, is it linear? No, if it was linear, it would go straight out like this. So the dose, the response is greater than just a doubling of a dose. You don't get a doubling of response, you get an even higher. So where this becomes important is that if, let's say you had them on 200 milligrams and you measured their plasma concentration and it was below 10, and you decide, okay, I want a much higher, I'm just going to double it. So what happens when you doubled it to 400? Now you're way above. Okay. So you have to be you have to know about those nonlinear so that here you've got to make smaller increments. So if you go up to a little over 300, you're going to start to hit therapeutic range. Okay, so Dilan is one of those drugs that can inhibit enzymes. It's a weird one. So it inhibits the enzymes that metabolize it, but it can also induce them. So it's a balance between its induction and its inhibitory properties.
So is that 400 and like 450, is that found in clinical trials?
No, no. Why do you ask?
Well, like, when are the dangerous dosages usually found or discovered?
You can have some people that can tolerate 400 all the time. So this is showing you probably composite data from a group of patients. But there are people, 400 is a reasonable dose for a lot of folks, and we'll keep them between that 10 and 20 target range. But in others, it may put them way up here. There are some people that need 600. Depends on the effects of their enzymes. Just their resting state, enzymatic activity, and then what the drug does to the enzymes itself. So the big concept to know is nonlinear means that's when I've got a drug that I'm dealing with, it's nonlinear, I need to make small changes and expect larger results. Where with drugs that have linear kinetics, if I double the dose, I'm probably going to get a double of effect. Other questions? Okay, so drug delivery systems. So I alluded to before is that we can change the way a drug is packaged in order to deliver it to a different part of the gut or bypass parts of the GI tract where the drug can cause adverse effects. So this science is just far out there. I don't know that I understand all of it. I can tell you some of it. Nanotechnology with cancer is just phenomenal. That the work that they're using to deliver chemotherapy into a cell and not to a viable cell, and to affect a change without causing any problems to normal cells. It's incredible. Liposomes we've used for a long time because we can package a drug in a liposome. The body doesn't do much to it. It kind of ignores it. It can kind of go wherever it wants, and the body just lets it go, and we can deliver a drug that way. So targeted drug delivery is a huge technology development at this point, mostly in the area of cancer, to try to avoid the bad adverse effects of the chemotherapy agents. So those are more limited, and that's probably where you'll see that, but I think that will grow as that technology becomes more adaptable. Controlled release drug delivery systems, very common, very common. So you'll see this often, a drug name will incorporate and let you know that it's a controlled release product. So they'll use words like XL, extended release, ER, extended release. So those kinds of terms on the end of a drug will tell you that they have changed or modified the drug to be released over a long period of time. So we usually don't have to give it as often. So one of the things I want to raise your awareness is that anytime you do that, use a controlled release drug, that's good, but you cannot alter those formulations without causing a lot of change in the release of that drug. So this would happen probably more in kids or people who don't like taking drugs or the elderly. So if a drug, sometimes they're large drugs and so patients will want to break them. Well, if you break them, then you expose the inside of that drug then to the body in ways that will change its absorption or release characteristics. So controlled release products you never want to alter. You don't want to cut the tablet in half, you don't want to crush it up. Patients like to crush up drugs and mix it in applesauce because it's easier to take. Some people have a real problem in just swallowing a tablet. And so to do so, they'll put it into they'll change it, crush it up, put it into ice cream, that's a favorite, or applesauce, or yogurt. Okay. So that's one thing I want you to remember as we go, never, never alter a controlled release product unless you've talked to, call the pharmacist and ask them. Or it can be made up in a different way, or there's lots of product alterations where it may fit your patient better. Prodrugs. So prodrug is where you give the parent drug, but the parent drug really doesn't have much activity. The parent drug is just a way to usually to get past first pass, commonly. So we call it a prodrug because it precedes, it's a precursor of the active drug. So then we'll take advantage of what the liver will do, and we'll give it a drug that's inactive, and we know that the liver's going to change it, and when it changes it into the active drug. Plavix, a drug that is used for, it's like an aspirin-like action, platelet inhibitor, so we use it in folks who are prone to clots. That drug is a prodrug, and so we rely on the liver to change it into an active drug. So now we're getting to where we know so much and we're more sophisticated that the ability to metabolize that drug into an active drug is genetically based. So some people are rapid metabolizers, man, they can take that drug, they're called ultra rapid or ultra metabolizers. They'll take that drug and they'll just spit it out into the new stuff. And then we've got others who are very slow and it may take them days to metabolize that drug. So now the nuances and differences in people start to show up. And so that's why differences of effect. Okay. Questions about any of those? Okay, let's talk about dosage forms. Here more, I just want you to start to be familiar with terminology, and we're going to talk about which ones of those are affected by first pass and which are not. Oral, most common. It's usually the way people want to take a drug. They usually don't like taking them through by other means. This is most convenient. So we have tablets and capsules, and we have gel capsules that are liquid inside and gelatin on the outside. We have, again, the sublingual, those are under the tongue. Often sublingual will bypass first pass, and they're very quick. So sublingual nitroglycerin, somebody's having a heart attack, or chest pain, we tell them to put that nitroglycerin under their tongue. rapid absorption, rapid effect. Buccal, so in between the cheek and gum. So this would be, not that many drugs used that way. We use like nicotine gum. We will ask the person to chew it, but we will then ask them to park it in the buccal cavity, and that's where absorption of the nicotine will occur. So that's one example. Effervescent tablets are another, not very common, but there's a few potassium replacements, aspirin as an effervescent tablet. Lozenges, melts, those are usually more rapid. Anything that you can get to a liquid more quickly is usually going to be absorbed faster. Liquids can come as elixir, solution, suspension, drops. Usually that's referring to the pharmaceutical end product. So syrups have a definition. Syrups are by definition about 65% sugar. And that's because they inhibit the growth of bacteria. When you put that much sugar in there, lo and behold, bacteria cannot grow. So that's why we use sugar a lot to in price, but and it makes it taste better. Or alcohol. Suspensions are just that. You've got a drug that is suspended in some type of vehicle or drops. So antacids would be a suspension. So any drug where you let it sit long enough and it falls out and you have to shake it up, that's going to be a suspension. We also have powders that are liquid that are used for oral consumption. Miralax comes as a powder and you have to mix it before taking it. Metamucil would be like that, same kind of, fall in that same regard. So most of these, I think, if you look at this diagram that I gave you, this one shows you most things that enter through the oral or rectal are then absorbed and enter that portal system. So all of these are going to be much more impacted by what the liver does to them. So first pass will affect all of them to a degree. And so bioavailability becomes important when we're talking about those forms. Okay, come back to that. Topical. So topical is usually anything we put on skin, sometimes what we would put on a mucous membrane. So here we're usually going to be using creams, ointments, gels, or transdermal products, patches, or powders, dusting powders, like this is tolnaftate for athlete's foot. Okay, so let's go back and look at what, so often we'll use topicals because it gets around first pass. The way it's absorbed, it will go right into the bloodstream and it won't have to go through the liver. We can get right into systemic circulation. So that's why you'll see doses of like estrogen products will be different. What we give orally, what we give in a cream, and what we use in a transdermal product is a lot different because we can get directly into the bloodstream. Okay, topical eye. So usually we're talking about either drops or suspension, solutions or suspensions, or ointments. And here the absorption, systemic absorption is variable. Just it depends on the drug, but usually you can get some out of that. But if we go back again, I don't know if it listed eye. Here I'm not so sure. I'm not so sure if it would fall into, I'm not sure where it falls. I don't know if it's under as much a liver metabolism or not. Usually we're looking for very local effect. That one I'll have to check. Then we have vaginal, intrauterine, rectal. Here the absorption out of the genital area is really different. We can use sometimes creams, steroids, or hormonal products, and the absorption is really different from other parts of the body. Some of it's less and some of it's accelerated. But some of the dosage forms you find in this, for these regions, would be like a contraceptive film for rapidly dissolves, or rings that are contain contraceptive products that we can insert for a 3-week period and let the drug leach out of that ring. Or creams or suppositories for either for rectal or intrauterine devices, or vaginal tablets. Just to kind of introduce you to the scope of those. Then we have intravenous, intramuscular, subcutaneous, intradermal. So IV, again, 100% bioavailable. Here, you usually will get higher bioavailability with your IM and sub-Q. And your, if you go back, here you're talking, again, you are bypassing the gut. So here you're usually, your bioavailability is really good. Inhalations, we have inhalers, and there's different types of inhalers. There's aerosols and there's dry powder. There's liquids like what we use for intranasal steroids are common, or giving the flu vaccine. And these are rapidly absorbed, they bypass the liver, and that's it. Questions?